come to the second last session, and it is very heartening to see so many audiences still. We are starting with our session is on HIV and hepatitis, and the first session is HIV and hepatitis, hepatitis C co-infection among IDUs, and I call upon Dr. Sunil Solomon from USA. Dr. Sunil Solomon is an associate professor of medicine, Johns Hopkins University School of Medicine, and he has received awards from NIH and ICMR.
So good evening, everybody. I thank the organizers for having me present on HIV and hepatitis C among people who inject drugs in India. So why is drug use that important in India? I don't know how many of you realize, but India is present right between the Golden Triangle and the Golden Crescent. So these two regions of the world are the largest heroin-producing regions globally. And we have drug trafficking routes coming into India from both sides. So the Northeast, the epidemic has been endemic. Drug use has been existing there since the 1980s, whereas the Golden Crescent is much newer. It's only over the past 5 years we have drug trafficking routes coming into India from the northwest side of the country. And as you would expect, India probably has the largest number of opiate users anywhere in the world. According to the UNODC report, there are approximately 3 million opiate users across the country. So yes, so drug use is a huge problem in India. And if you look at the latest reports, I know the narco sentinel surveillance reports have been showing that overall the number of people infected with HIV has been going down. But if you look at the actual prevalence and what's happening in the different subgroups, the prevalence has pretty much stayed stable, and some may even say it's actually increasing among drug-using populations. So drug users really are a population with the highest burden of HIV infection in India currently. So we did a study in 2013 where we sampled 1,000 drug users from 15 different cities across the country. So each of these circles represents an area, a city in the country, and each of these circles represents 1,000 drug users. And as you would expect, in the northeastern parts of the country, you saw an extremely high burden of HIV, so upwards of 30%, 35%, and the big 45% you see there is in the city of Moreh, which is actually on the border between India and Burma. But what was really remarkable was the incidence. So this incidence was estimated using a cross-sectional multi-assay algorithm, which used the HIV BED, the avidity index, the CD4, and the HIV RNA. So what you actually see here is the areas with the highest burden of HIV don't necessarily have the highest incidence, but it's areas like Kanpur and Bilaspur and Amritsar, which are like much newer epidemics, which are just taking off, where the prevalence is relatively low, but you're seeing a much higher incidence, suggesting that these epidemics are on their way up. And in terms of hepatitis C, it's almost impossible to work with drug-using populations without talking about hepatitis C. It's pretty much the exact same picture. So you see almost double the HIV prevalence of hepatitis C across anywhere in India. The northeastern states obviously have a 60-65% prevalence of HIV. The northern states have it somewhere around 50%. But as drug use is much newer in the northern states, you would expect like Punjab, Haryana also to start seeing prevalence of hepatitis C somewhere around 60 to 65%. But what's more alarming is almost 1 in 5 drug users in several of these cities is co-infected with both HIV and hepatitis C virus infection. But if you look at it the other way around and you look at HIV-infected drug users, the prevalence of hepatitis C is almost 100%. Because in the natural history of drug use, most people pick up hepatitis C first and then they pick up HIV. So what does the HIV care continuum look like? So this is again from the same 15 cities across the country. So the big orange bars that you see is the average across the different cities. So about 40% of HIV-infected drug users are aware of their status, and that's the rest of the continuum. So the two blue lines you see on the top of the screen and the bottom of the screen are the cities that were doing the worst and the cities that were doing the best. So Kanpur, for example, had like almost nobody who was HIV infected who actually knew they had HIV. So there really is a long way to go in these different cities when working with drug-using populations. Now, when you look at the same thing with and if you're looking at the 1990 continuum, which somebody spoke about in the previous session, what we have for drug users in India right now is 41, 44, and 15. So we really have a long way to go to get to the 90. And if we have to achieve the 90, you have to focus on all populations, not just the general population. And when you're looking at the hepatitis C care continuum, it's almost like a cliff, right? So you see the infections and almost no one is aware of their status. Only 5.8% of all hepatitis C infected drug users were aware that they were infected with hepatitis C. And this is a sample of 5,777 hepatitis C infected drug users across the country. And the biggest reason, almost 50% of these drug users had never heard of hepatitis C. So this varied completely. So if you went to the northern states like Punjab, it was closer to like 80 and 90% who had never heard of hepatitis C. Whereas if you went to the northeastern states like Manipur, people were actually talking about when is sofosbuvir coming, when is decladisvir coming, because the knowledges are just different across the entire country. So I guess the first question is, how do we improve HIV testing? Because that's your first step. Like, how do we get to that first 90? With the hope that once you get to the first 90, those effects will trickle down along the way, and eventually you will see improvements in both the HIV and the hepatitis C care continuum globally, across the different populations. So in terms of testing, there are different approaches that can be taken. So community-based testing is something that people have been attempting in different places. I think NACO is also trying to come up with mobile vans, which they can go to different venues and do venue-based testing. But another thing that we can do is integrate hepatitis C testing into services drug users are already using. For example, buprenorphine programs and methadone programs which are there, which are standalone programs run by the psychiatry department. So if you could integrate spot testing or point-of-care testing for hepatitis C and HIV in those venues, you actually will start testing a lot more drug-using populations for these infections with almost minimum additional cost. So the other thing about drug-using populations is that a lot of them are hidden, so you can't really find them. But they are all connected to each other. So when I'm talking about network connectedness, so this is essentially what we're trying to do. So this is how recruitment actually took place in Kanpur. So for those of you who don't know, Kanpur is almost the middle of India, that orange dot over there. So you start off with 2 seeds whom you believe are the 2 most influential and connected people. So you do some focus groups, try to understand who these 2 people are. You give them 2 coupons, tell them go give it to any 2 of your friends whom you inject with, and ask them to come into the study. So they bring in 2 people for the study, and then those 2 people are given 2 coupons, so they bring in 2 more people. So it's almost like a chain referral process where you keep giving coupons out, and drug users recruit other drug users. So in Kanpur, for example, over a span of 118 days, which is less than 4 months, we were able to recruit 1,000 drug users. And as you can see from the yellow and the orange and the maroon, almost everyone was either Hep C infected or HIV Hep C co-infected. So the HIV prevalence here was 31%, 97% were unaware. So you were able to use the networks to find people who were unaware of their HIV status, and for hepatitis C, it was a 68% prevalence and 100% were unaware. So this really is a very unique and a cool way of trying to find drug users by having them bring in their own partners. So the next big problem is linkage to care and getting them on treatment. So I guess the first thing you need to do is figure out what the barriers are in terms of figuring out how do you get them to treatment. So distance used to be a barrier in several places, but it isn't anymore because there are so many ART centers across. Treatment literacy programs are something, especially for hepatitis C, where drug users need to be educated that HIV is not harmful, ART is not harmful, because a lot of them, especially in the early 2000s, when treatment was restricted to people who were under 200, people would start treatment and then they would die. Right? So people have this thing embedded in their heads that if you start ART, you're going to die. So this is something that you have to educate populations that ART is not harmful, people will not die if you start antiretroviral therapy, and also tell them there is treatment for hepatitis C. So peer health navigators, social support, and integrating HIV and hepatitis C treatment into other existing programs for drug users are also things that can be attempted, especially for hepatitis C treatment, because it's like 12 weeks, short course treatment. It could be easily done as a DOT program integrated with opiate agonist therapy programs. And one of the biggest barriers we found in terms of linkage to care was they said if they had to go to a care center, they had to lose their daily wages. Because most of these drug users across the country are daily wage earners. So we said, okay, so what if we give you the 150 rupees you would earn if you actually went, registered for ART and brought us a book back with evidence that you have actually gone to the ART center? Because once you get into the ART, once you can get them to go to the ART center, they get into the system, they get all the social support and everything else that the ART center has already had. So the biggest barrier was getting them there. So we offer them 150 rupees if they actually went to the center. So as you can see from this, it was almost it was like a 3 times higher probability of people initiating ART if you just gave them 150 rupees to go and start antiretroviral therapy. And then in terms of improving viral suppression itself, you have to address the substance use issues. Either get them on opiate agonist treatment, or trying to get drug users to be adherent when you haven't addressed their substance use issues is a huge problem. You have to ensure timely refills. There are a lot of different ways of doing it. You can do SMS, IVRS. There are pill bottles like Weiss Pill and Simple, which remind you when people are taking medications, not taking medications. Directly observed therapy, and MyDot is a video-based directly observed therapy, which is an app that has been developed. It's being used in the US. We're trying to modify and adapt it for the Indian setting using Indian languages. And directly administered ART is another approach. Peer health workers, case managers, these are all different approaches that are being tried. And I guess the most important thing is ensure adequate supply of treatment, especially if you're going through the government programs, because we have encountered situations where drug users have had to go back every week or every 2 weeks occasionally when there are some shortages, and expecting populations to go that frequently into different programs can be challenging. So essentially like a 1 month or 2 month supply of treatment will really help move treatment along much faster. And there have been trials in the United States where they've looked at financial incentives for viral suppression, but financial incentives for viral suppression will only work on 2 conditions. One is we actually have to have viral load measurements in the different programs, and you have to be starting off at a very low level. If you start off with higher levels of suppression, like what they did in HPT and 065, the cost benefit of the actual incentives will not work that much in your favor. So I just want to tell you quickly about a trial that we've just finished in Chennai. We don't have the final data yet, but this is a field-based, directly observed therapy for hepatitis C among 50 drug users in Chennai. So when we started the trial in 2013, there were only in September of 2015, there were only 2 pan-genotypic regimens in India. One was soft-peg-riba, and the other one was soft and riba for 24 weeks. And as you know, for hepatitis C treatment, genotype matters on your regimen choice and your treatment duration, unlike for HIV where subtype doesn't make a difference. So what these people essentially got in one arm, the soft plus peg and riba arm, they got weekly peg injections, but all their tablets were given to them on the field by one of our field workers, and they recorded their biometric as proof that they actually saw the participant. And for the soft and riba, it was the exact same thing, but all the dosing happened at home. We had them come back every 4 weeks for CBCs and LFTs, especially because you're using ribavirin. It's very important to look at safety labs. We never did any on-treatment HCV RNA monitoring. We never did any HCV genotyping because we were using pan-genotypic regimens, and there really are no stopping criteria based on HCV RNA right now. So we don't have the final results, but what I can tell you is out of the 22 people who have completed treatment in the soft, peg, and riba arm, all 22 have been cured. Right? So you can actually do it. You can treat drug users, you can cure drug users, and there are very innovative ways of doing it. So these are the drugs we used, but we did run into problems which are real-world challenges. I know you all know about the floods we had in Chennai, so we did have stockouts where people in the soft peg riba arm missed like 4 to 5 days of doses because of the rains, but because they had the peg injection, they had that coverage over that 5-day period, and all of them have been cured, as in they have sustained virological response 12 weeks after the end of treatment. So I want to end with a structural intervention. So most of the interventions I talked to you about are about individual level interventions. So we are currently doing the evaluation assessment for a trial which is trying to evaluate a model where we're saying, like, what if you provided all the essential services MSM and drug users needed under a single roof? So for drug users, this is opiate substitution therapy, needle syringe exchange programs, HIV counseling and testing, ART, TB treatment, couples counseling, STI management. If you provide all of these services under a single roof, how does that affect the HIV care continuum in that population? So this is the overall design. So we did a baseline assessment. So we have 6 intervention and 6 control sites for the drug-using populations. So the clinics have been running for I guess 2 years. They started in June 2014, so they've all done. And the evaluation assessment, the extreme right, started in August of this year. So we will complete in February, so hopefully by March or April of next year, we'll know whether this model of care actually worked. Our primary outcome is self-reported HIV counseling and testing in the prior 12 months. So still focused on that first step of the continuum. So as you can see, the orange circles and the triangles are the sites that were used for the drug-using populations. And they're all over the North India and Northeast India. So this trial was done in collaboration with the TI division of NACO. And so the sites were selected based on the data that NACO had and based on inputs from both the NACO investigators, YRG Care, and the Hopkins team. So this is essentially what the integrated care model is. So it's for drug-using populations. We built it around opiate substitution centers. So we have 3 clinics within the government hospitals in Ludhiana, Chandigarh, and Bilaspur. And we have 3 clinics nested inside NGOs in the Northeast in Dimapur, Imphal, and Aizawl. So all of them provide opiate substitution therapy. So condoms are also provided there. Needle exchange, we do it both in the facility as well as field-based, where they go to shooting galleries and provide needle clinics. HIV counseling and testing happens on site. And so we have a link model for ART, where for the first visit, they have to go to the government ART center and get registered. And subsequently, the drug user himself only has to go every 6 months for his routine follow-ups. But all the interim ART supplies are collected by our outreach workers and provided to the drug users at these clinics. So this is what an average ICC looks like. So that's like a counselor. This is the person who's crushing the OST, our nurse, a physician room, and a waiting area. So it really is like a bare bones, very simple structure, which is almost very, very cheap to do. It's not like one of those fancy hospitals where you need a lot of infrastructure in place, because HIV treatment and hepatitis C treatment has progressed so far that the majority of the patients can be treated with minimal infrastructure. And to date, so this is a little dated, so we've seen over 10,000 clients across these places. We've done about 7,000 HIV tests. And if you look at the HIV care continuum, this is what it looks like. So it does look like we are having an impact on HIV testing, but it isn't trickling as much as we would have hoped further down the continuum. And so what we have done, because of the high burden, is we have also integrated HCV testing and treatment into these clinics in the last quarter of 2015. And so in the past 10 months, we have tested about 5,000 drug users for hepatitis C across these places. The average prevalence of hepatitis C in these clinics is about 45%. And so now we're working on actually integrating hepatitis C treatment into these centers. Punjab has a free program, so they've offered to provide free treatment for all the drug users through the government's Mukh-Mantri program. Imphal has a different program, so we are in talks with the different governments involved to try and get hepatitis C treatment also integrated into these different programs. So I think that's pretty much it. So thank you. I must thank all my funding sources, my collaborators, Hopkins, NACO, at YRG Care, all the participants of the studies, and all our staff. Thank you.
Hello. Nation in India, but I do in the United Kingdom. And I wondered what screening program you have in the prisons, whether you have any opiate substitute that you have available, which you can use when you're doing the needle exchange schemes, and what type of drugs the population, the injection drug users, are using. So those are my first 3 questions.
Okay, so I will start with your third question first. So the types of drugs being used in India are primarily depressants, all opioids and depressants. So there is a lot of heroin. You see a lot more in Manipur and in the bigger cities like Mumbai, Delhi. But we also see a lot of pharmaceutical drug abuse. Like in Punjab, for example, the majority of the drug use, at least from our samples, have all been pharmaceutical drug abuse. But even in the Northeast, it's very interesting because there's a lot of traffic that goes between Manipur and Burma, right? So Manipur has almost a 99% heroin epidemic. Whereas if you go to Mizoram, which is 1 state below, or you go to Nagaland, which is 1 state above, there's less than 10% using heroin. So it is a very different epidemic. So the primarily drug of abuse is heroin, followed by a mix of pharmaceutical drugs going from pethidine to dextropropoxyphene. So there are a lot of people also inject buprenorphine. And so it's primarily opiates, either synthetic or tablet forms. And then coming to your, I think your first question was about screening programs in prisons. So there are programs in prisons. I don't know how effective they are. There is really no clear data that has come out of prisons. I'm currently working with the Tata Trust, and we're trying to implement a prison program in one of the prisons in Maharashtra, where we want to do a complete screening program for HIV, Hep B, Hep C, and TB, including a chest x-ray. So once we get the program, so we have been talking to the prison staff there. So there is a doctor, there are some medications in place. So I know ART is not provided in the prisons, but prisoners are taken once a month to the government ART center. So I know the prison in Mumbai goes to JJ Hospital for their antiretroviral therapy. So there are some programs, but I don't know if it's a routine program where everybody is screened. I think your next question was about the opiate substitution. So methadone was available in India at one point in time, then it went away. So our primary substitution programs, all of them use buprenorphine. And we use this, the generic version is called ADNOC. There is a version of buprenorphine plus naloxone that's also available, which is Suboxone in the UK, and here it's called ADNOC-N, but that isn't being used. We still use ADNOC, because if you used ADNOC-N, it would minimize the risk of diversion. You could give them take-home doses of buprenorphine. But the government has also started methadone, has reinitiated methadone programs in Punjab as like a test program, and depending on what happens, they will scale up methadone also.
While people come up to the microphone, I can't resist one more question. And that's in prisons. Do they get consent before they do the HIV Hep C tests?
So Hep C testing is not done in the prisons. From what we've learned from the doctor who is in the Yerawada jail near Pune, so he actually said it's not mandatory. So they offer it to them, and it's up to the prisoner whether they want to get tested or not.
Any questions?
I am from Manipur, and by 1990, we have injecting drug users, so 80% of the injecting drug users were HIV positive. Out of them, almost 100% were HCV positive. 80% of injecting drug users were HIV positive, and almost 100% of them are IC positive. That trend is still going on, but HIV positivity among injecting drug users have gone down to 20 to 12% now. From the practitioner's point of view, the substance being misused now, abused now, is spasmoproxyone, and it is used orally. And most of the females, especially in Thawal district, they are using married females are using spasmoproxyone, SP. And the youngsters inject them, and most of the people comes with thrombophlebitis. Sometimes we lose a lot of peripheral vein thrombosis. That is going down. That trend is going down. People are not injecting. Those who are injecting are using clean syringes. Needle syringe program exchange program is successfully, I think it is there. From practitioner's point of view, I am working in the tertiary care hospital. Almost my patients who comes over there, they are of oral substance abusers, especially female. And we have not been able to do an epidemiological study of this. What will be the ramification of this substance abuse, I do not know. But substance SP use is very rampant.
I'm very sorry to interrupt, but we're running short of time, so please be brief.
So I concur I think the Manipur, in terms of harm reduction, is probably the best program in the country for drug users. And I also think part of why you're not seeing many new infections for HIV in Manipur is because treatment rates have gone up. Like if you look at HIV treatment coverage among drug users anywhere in India, Manipur has like 67%, no, sorry, some 50% or something of all HIV positive drug users are suppressed. So obviously there is much lower levels of transmission. In terms of SP, yes, I completely agree with you. There is a lot of SP use also happening, especially among women. And you do get abscesses when they inject it. But that's something I think it's more like from a society perspective, you need to actually do a lot of counseling. I know the church is involved in Manipur, so you really have to figure out what it is that's driving drug use, because most of us work with drug users after they've become drug users. The key to preventing HIV infection among drug users is to prevent drug use from happening, which is a whole different topic. So you really have to go back and figure out what's getting them into drug use and work backwards from there.
Thank you, Dr.
Thank you.
Solomon.